This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, patients pay their doctor a low monthly membership and, in return, build a lasting relationship with their doctor and have their doctor available at their fingertips.
Healthcare in our country is completely broken. It absolutely can be done a different way, and I'm setting out to do it. That's why I believe in direct primary care. I kind of liken it to car insurance. If you have a car, you should have car insurance. But you don't use it for everyday things like gas, oil changes, car washes. You use it for the big things like car accidents, engine blows, things like that. That's how healthcare should be. If you have a body, you should have health insurance, but it should be for catastrophic things, big things, like if you get cancer or if you get hit by a bus. It shouldn't be for the everyday things like preventative care, the mammograms and colonoscopies and urgent care visits and all of the maintenance things. Everything family medicine does, it should be low monthly fee or structured differently, but it should be patient pays out of pocket for that, very minimum amounts. And our insurance premiums should be very low because we're only paying for catastrophic things. So that, I think, is how we're going to revolutionize care in this country. And direct primary care just works no matter how you do it. I am Dr. Jenna Silakoski. I own North Idaho Direct Primary Care, and this is my DPC story.
Dr. Jenna Silakoski attended both undergraduate and medical school in Ohio, where she went to Ohio University College of Osteopathic Medicine. Graduating in 2012, she dedicated herself to serving our nation as she immediately took an oath as an officer in the United States Army. Serving as both a soldier and physician, she completed her residency at the Carl R. Darnell Army Medical Center in Fort Hood, Texas, and became a board-certified family physician in 2015. Since then, she has attained the rank of major and served in many roles, including medical director of an outpatient clinic and officer in charge for the family medicine residency clinic at Fort Hood, as well as providing care for soldiers and their families across the spectrum from cradle to grave. As early as medical school, Dr. Silakoski saw firsthand many of the challenges that existed with traditional healthcare, both in the civilian world as well as the military world. Difficulties with access to care and the lack of time able to be spent with patients left her searching for a better way. As direct primary care surfaced as an answer to physician and patients alike, calling for a way to bring quality-driven, relationship-based care back into medicine without the complications of insurance, Dr. Silakoski seized the opportunity to bring care directly to her patients. Dr. Silakoski raises her 2 young children, AJ and Everly, with her husband Ryan, who works for a company that supports our military. She enjoys painting, exploring the world with her family, and continues to pursue her dreams in the community of North Idaho. Welcome to the podcast, Dr. Silakoski.
Thanks. I'm so glad to be here.
It is so cool to talk with you because and I was saying this before the interview, but my dad also was at Fort Hood. So thank you for your service to the country. And thank you so much for being on the pod today.
Thank you. Thanks for your family's service and thanks for having me.
So you grew up in Ohio and then you made your way to Fort Hood, Texas, where you served as a soldier and a physician. And then you ended up in Idaho. So I wanted to go back to first that transition from Ohio to Fort Hood. And I wanted to ask what led to your decision to serve and especially to serve as a physician in the U.S. Army?
It's an interesting story. I will date myself when I say this. I was in high school when 9/11 happened, and I felt I needed to serve. It was just something that I wanted to do. And I thought about going in right after high school and then decided I should get a degree first and go in as an officer. So I started college and then forgot about it as I decided I wanted to go to medical school. Then when I learned that there was a scholarship offered for med school through the military, I just applied for that and got it.
So when you got into the Army and were an officer and a physician, what was life like at Fort Hood for you?
It was a little different than I expected. I expected it to be more Army and more military and less corporate medicine, which is what it ended up being. The military at that time modeled their system after Kaiser Permanente, and it was RVU tracks and encounters per year generated or seen. And it was just see more patients in less time with less resources, always meeting the metrics. And I hated it. I decided I didn't want to be a doctor anymore very quickly.
It's so sad because just knowing the journey that is in front of you when you're a pre-med dreaming about medical school and it's this, the big shiny pearly gates that you aspire to achieve. And then to hear you get to the point that you are a physician and just saying, if this is not what I envision medicine to be, that's really sad. And so I want to ask you on that point, when you talk about this corporate medicine model, that when you say Kaiser Permanente, I know exactly what that means living in California. But when you describe that, what was your day-to-day clinic experience like? What were your duties like on an everyday basis?
It varied vastly. Every couple of years, the military changes your location or your job. I was fortunate enough to be at Fort Hood for the majority of that time. And after residency, my 4 years of continued active duty included being a medical director for a community-based medical home that served about 8,000 enrollees who were retirees or family members living off base. And I had a couple physicians that would come and go and a bunch of mid-levels that I was in charge of. And it was a lot of chart review and administrative type work, but not enough time to do it. We saw 20 patients a day, which is on the low end, actually. If I were other places, it would be more. But I still had to take time off to do PT tests and take time off to go to the range and take time off to go to TDYs, temporary duty stations, to do trainings. I had to go multiple times for between 2 days and 2 weeks to DC or San Antonio or just multiple different places to get extra credentials and more things like that. I had to help with getting our medical home PCMH certified. And that was not easy. But on a day-to-day basis, it was seeing 20 patients and then reviewing charts and just a lot of administrative stuff.
Wow.
I eventually became the medical director for the residency clinic. And that was even worse because the expectations and requirements were so unrealistic that it just drove me down. It was awful.
It's just crazy just to hear the similarities between the fee-for-service job that is not in the military and to hear your experience. For me, it's unexpected. So
yeah, I didn't expect it to be like that. I guess I wouldn't have known until I got there and did it. I'm glad I did it. I'm glad I got the experience. I don't think that I would have the guts to do something like this if I hadn't gone through that, probably.
It gives you a lot of self-confidence, I'm sure, in the ability to do or take on anything if you can handle all of that on your plate. In terms of direct primary care, between when you were at Fort Hood and going to North Idaho DPC, how did you come to learn about DPC?
Oh my gosh, interesting story. So I decided I hated medicine and I was going to quit. And my husband said, Jenna, you can't quit. We have too many student loans. So I said, what else can I do? I can work for the insurance companies, which are what got us into this mess in the first place. So that's out. I could try pharmaceutical. Don't really want to do that. I didn't want something big. I know that because I think when things get too big, you lose the value. And so I said, what else could I do? I could do a different residency. I could do academics. I've already done that. I don't like it anymore. I used to love it. Then I learned about DPC. I heard someone talking about it on an elevator. So I went and started looking about it, and I found the DPC group on Facebook, which I think everybody knows about at this point. And I just started reading and reviewing and saying, okay, when I get out of the Army, when my commitment's done, this is what I'm going to do. If I stay in medicine, this is what I'll do. So I started building a business plan, and I was going to just start my own practice when I got out slowly and work urgent care on the side. But then in 2018, as luck would have it, I had this amazing opportunity, and I bought a medical practice on Facebook.
That's amazing. So tell us more, because buying a medical practice on Facebook, that definitely, if people weren't really tuning in at that point, I just want to emphasize, you just said you bought a medical practice on Facebook. So please tell us more.
I love it. Okay. So it really wasn't quite like that. I mean, it was. I met this gentleman, Dr. Richard Samuels, his name, amazing family physician I now have come to know, who was interested in selling his practice because he was going to be retiring in the near future and was looking for someone to come in and take it over like this. So my husband and I, right after interviewing at 2 rural jobs that were offering $250,000 a year, we didn't drive. We flew here and we met him and his family, and we saw the practice, met the employees, saw the area, fell in love, and said, this is it. I had never even heard of Coeur d'Alene, Idaho before, and we don't have any family here. We had 2 very young kids, 2 dogs, 2 cats. All of us picked up and moved to North Idaho. I mean, we had a business valuation, hired attorneys, got a CPA, things like that. So we did it. I think we did it right. And I'll say 6 months into that transitioning period, he had to retire earlier than expected due to some health concerns. It ended up being me alone with all of these patients. I was terrified. The attrition rate I was already worried about because you can't buy contracts. I couldn't buy patients. So I was paying for the name of the building, of the practice, and I was paying for the minimal amount of equipment that we would have as a DPC practice anyway. And so I was terrified and worried. And it turns out my attrition was, I think, about 3%. It was so low. Patients, number one, didn't want to go back into the system at all. And number 2, they knew the staff and the employees, and that all stayed the same. So I think that they felt really comfortable.
That's amazing. When you were starting and you explained how over the 6-month period he had to retire early, how was that for you in terms of onboarding all of those patients as your own then? Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
Oh, let me tell you how I thought it was going to go. I thought that I would get here and within maybe 3 months, I would learn he had capped at about 400 because he knew he was going to retire and he wanted to transition that over. So I thought I would come and I would learn these 400 patients really quickly in the first 3 months and I'd be good to go. It did not go like that. No, it was a lot harder than I expected. But I think it's also because I talk a lot, probably too much. Instead of having a person in for an initial visit where I'm like, hey, I'm the new doctor. These are your medical problems. Yes. These are your meds. Yes. Okay, great. I'll see you when you need me, or I'll see you for your physical. I would see them for like an hour and a half and chat about their family and learn about where they were from. And so that might also have something to do with why they didn't want to leave, I hope. But
it totally worked out in your favor. And, even just your intro video on your blog when you joined the practice, it's so people can hear your voice, but that video was so personable. And so I'm assuming that broke down a lot of barriers or anxieties about having a new doctor at their DPC.
I hope so, because I really do think of my patients as my family, and I want to know them and I want to serve them. I want to work for them. There's no middleman. I don't want to answer to their insurance companies or the administrators telling me how long I have to see them. I want to work with them, only with them. And it's just us. I did have a couple people leave because I was a young female and they wanted, they were used to the older male, and that's fine. I much rather a female deliver my babies than my male colleague. I don't want him to see that. So I understand that. I've actually had 2 or 3 men say, I was going to quit, but I decided that since you were Army, I'd give you a chance. And I'm really glad I stayed. And that just made my day. I'm glad that they can feel comfortable and I can have some things in common with everybody.
Definitely. And right now, what is your patient population like?
It's so varied. I do cradle to grave. My youngest patient right now is about 4 months, and my oldest patient is 92. I have a mix of, I break them up like this. There's government, which is Medicare, Medicaid. That's about 15% or so. There is private insurance, like all the PPOs and HMOs and BUCAs, Blue Cross, all of those. And that totals about 50%. And then the other 50% is cash paying or health shares. And so I lump those together as well.
Gotcha. And in terms of the staff, you mentioned you had the staff come over with you. Who was at the clinic before who has stayed on with you?
All of them, luckily. And that was our receptionist, Kim. She is amazing, knows everybody when they walk through the door. It is incredible. She can look at a phone number and know who it is on the caller ID. And I'm like, oh my gosh, that's another reason it's so helpful to keep someone on who already knows a lot of the patients. And Rebecca, who was receptionist / medical assistant in Idaho, you don't have to have an MA certificate. So Rebecca happened to be Dr. Samuel's daughter, and she is incredible. I mean, Kim and Rebecca are both incredible, but Rebecca very quickly took on a lot of responsibilities because I didn't think it was going to be as hard as it was to learn all of these patients and do everything medical wise. I thought I was going to have more time. Also, not really putting weight on the fact that I had a 2-year-old and a 4-month-old at the time, but that made it a lot harder. But she immediately took everything and just started running with it. So she's the manager now, and she is incredible. She
Awesome.
can do everything. Yeah.
Going back to the transition when you were coming on as the primary doc and Dr. Samuel was leaving, how did that go with Rebecca and with Kim in terms of you were really new to them still, and they were going to be your team going into the future to continue taking care of the patients? How did that work in terms of them getting on your side to talk you up in an amazing way to patients as they were getting their get to know you visits in with you?
I was floored at how well it went. I was so surprised. I was really worried about that because not only were they there and Rebecca was his daughter, but also his wife works there still, and she's still there too. She's a part-time counselor, which is included in our membership. And so I was really worried that family dynamic wouldn't allow for or support an outsider. And I was unbelievably wrong. I could not have asked for a better crew to come into. They were supportive. They were so helpful, just teaching me about the area and the things I didn't know and the specialists. And I never had to do a prior auth in the Army that I can recall, I don't think. Or I think people always did these things for us, which was great. But again, that's what drives up a lot of the overhead. And so they accepted me. And I think that they were probably just as fearful. They were probably like, am I going to lose my job? Was she going to be nice? How is this going to change? Because he did things very different. He was very old school. He kept double records with paper records still, in addition to their online chart. And he is very meticulous, very detail oriented. He is an incredibly brilliant man. And had he been in my spot, he probably would have been able to do everything by himself. Um, but when I came on and I couldn't do that, I just started handing stuff to Rebecca, and they accepted me. I think Rebecca's my age, so she and I are very much similar. She's way more tech oriented than I am, but we're at least on the same page as we don't need to keep double records of paper and things like that. Oh, they were doing paper faxes. We changed it to internet e-fax. And so Kim, she was more of Dr. Samuel's generation. And it was, I think, and she's also like me in technology. We are not good at technology. We need Rebecca. But she has an incredible knowledge of people, and she's so personable. Everybody just loves her so much. And I'm so glad that they were willing to stay.
And I want to ask about finances, because with you having moved to buy a new practice, and just when you talked about the CPA and the lawyer and all the costs going into then buying the practice and then paying yourself and paying your employees, how did that all work for you in terms of, did you have to take out a loan, or what did that look like?
I did. I took out an SBA loan. Now, looking back, feel like I got an incredibly good deal on this. We had spent most of our savings because we had to put down payments and we had to travel here several times. We had to hire attorneys. And so if patients quit, then I wasn't going to have a paycheck and I wouldn't be able to pay the loans. So that was a little scary. But the bank here, they were incredible. It was a regional bank, and they didn't know me from Jack. You know, I'd been in the military. I'd never owned a business. Like, I'd never even been a civilian doctor. But they were like, yeah, you'll probably be fine. Doctors don't usually default on their loans. Here's a house loan. Here's a car loan. Here's your practice loan. And here's a line of credit. I didn't use the line of credit at all. Never needed that. That was good. But things sped up incredibly fast. It went faster than I could have imagined. I'm now bringing on a partner at the end of the year. Dr. Odom is going to be here in November, and we are so happy to have him. He and his family are incredible, and patients are just like knocking down the door. I just can't keep up with it. I'm exhausted. Regarding finances, the practice was generating about a paycheck of about $10,000 a month for the doc at that time. And that was enough to pay the loan and the bills and things like that. So that was great.
After getting your finances situated and knowing that you had staff to pay, but the patient population hadn't really changed much, how did you go about benefits? Did you have benefits that you were paying that were already established for Rebecca and Kim and Donna?
Yeah, at the time, they had an option for simple IRAs, and that was pretty much it. And a membership to the clinic, they were allowed to have medical care. I would like to consider paying for a membership at a different clinic, because I think it's a little easier, you can have more objectivity if you're not their employer and their doctor. But so I restarted the IRA, and I do bonuses, holiday bonuses, and I do 3 weeks of PTO, 6 paid holidays, federal holidays, in addition to the 3 weeks. And so far, that's it. I'm looking at dental and either a catastrophic plan or something like that for the future.
Awesome. So as you got your feet established, as you became the solo doc, did you experience much growth after having onboarded those 400 people?
Oh my gosh. My average was about a net gain of, I think it was a net gain of 7 a month for the next 6 months. And then in January and February, I was averaging 25 a month. So I just couldn't keep up with it. So I closed my panel at about 565 and just let some attrition happen with people moving or dying, things like that. And so now I'm at about 555, and I've opened it back up again, but I've got a huge waiting list, and I really want people to go to Dr. Odom because I want to talk him up and say how amazing he is. My attrition rate is probably about, I haven't calculated it this year yet in 2021, but from the time I opened to the end of 2020, it was about a little over 1%. It was like 1.3%. So I think it was pretty good.
Incredible. Yeah. Now, I have to ask, with having a 2-year-old and having a 4-month-old, when this all started, how do you balance family life now that you have over 500 patients? Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited, customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
So I now also have a virtual assistant who is very helpful, but I am not good at setting boundaries at all, but I'm trying very hard to do that when I'm at work. It's work time. When I'm at home, it's home time. I put my phones away. I leave the ringer on in case there's an emergency, but I put everything away and I try to be present at home. And I was working 60, 80 hours a week in the Army. I think that I only work about 35 hours a week, but my husband would beg to differ. I think I love it so much. I just want to do everything about it.
That love of working on the business rather than working in the business, it really is something that a lot of DPC doctors have said in terms of on the podcast and just in personal conversations, that you're working harder, but it's not working harder to the point of burnout. It's working harder because this is a baby and you love it. So that's amazing.
Yeah, I don't foresee burnout in this position because everything I do is just a little bit different every time. And it's always something for me that I want to do. So if I don't think it's important, then I'm just going to say, no, I'm sorry. And I don't have a boss to answer to tell me you have to do this and you have to meet those metrics. And I'm going to just say, nope, not going to do it.
When you speak of boundaries, I want to ask, what words of advice would you give to others who might be challenged with setting boundaries with their practice or with their patients or both?
I would be a really bad person to ask. So those people who can do it need to tell me. So far, what I have found is saying up front and being very clear during the meet and greet to say, I am not a concierge doctor. I think that there is a big difference. And I have a family and my family is very important. I'm human. I will be available for you. I will get you in very quickly. I will answer your texts during business hours. But after hours, my kids, my family, it's their time. And they have been incredibly respectful about that. I'm the one that breaks the boundaries because I know when they text me and they say, I need a refill on this, I know that it can wait till tomorrow. I know that I can, but I just can't let it sit there.
Awesome. Now, previously in one of the DPC Docs feeds, you had written, I just ran a report of my interactions over the last 15 months. I averaged them over 21 working days in a month and counted 1 week out of the office. So the total number per average per working day.
So it was total number of whatever it was. And then afterwards was the per day. So
Gotcha.
If I averaged it over 21 working days over that year, it would be, so like if I saw 100 patients that year and I only worked 10 days that year, I would have averaged 10 patients a day.
Gotcha. So these are some amazing pieces of data because I think that this is where, even though you talk about that you're not the expert at boundaries, I think that this is a huge step in the right direction to taking control and holding the reins, so to speak, over your business because you're actually knowing where your time is going. And so one, I wanted to ask, how did you get the data that we're about to talk about?
I pulled it from Atlas MD, the EMR. That's the one I use. I switched when I came on, we were using Practice Fusion and I liked it, but there was so much good about Atlas that I decided to make that switch. And it is really hard to switch EMRs.
Just delving into that right there, how did you guys as a team make that all happen and how long did it take?
It took longer than I expected. Atlas support was really good in getting all of that moved over. So it all went over as PDF files and attachments, but it took, I think, a couple months maybe. And it was a little more intuitive and there were so many good things about it that it was really easy to just kind of transition for me, it was because I hadn't used Practice Fusion that long. For them, it was a little harder because they had used it longer, but it was quick. It was probably within a week or two. It was pretty routine, I think.
Nice. Now, for the data, the big ones that I gleaned from your list, and I'll post the rest of the list on on your accompanying blog, but total chart interactions was 12,956, averaging 41 per day, and calls on your cell phone, 1,712, averaging 5.4 a day, and SMS messages, 16,359, averaging 51.9 a day, and emails, 3,354, averaging 10.6 a day. So just from that amount of data, your practice seems to be very heavily technology capable, one, in that people love to communicate with you, it seems, through messages on text. Was that representative of what the patients were doing before you came on?
No, it transitioned. It was very traditional. So he converted his fee for service practice to DPC. So it was very traditional. They would call the front desk, they would make an appointment, they would, come in and talk about things for follow-up, where I text them, hey, your labs were normal.
When you set the time aside, like you mentioned before about this is work time, this is family time, what portion of your day do you spend doing the communication? And do you have a set time for that, or do you do it throughout the day?
I just do it throughout the day. Usually I have admin time, but usually before my first patient at 9, and then admin time after my last patient at 3:30. But I'm usually walking through the door at 5 till 9, and I'm usually out the door right after my last patient. So I have to do it during the day. Prior to the pandemic, I used to take an hour and a half lunch. So I'm in the office now about 9 to 5, and I do a 30 to 90-minute lunch depending on the day at this point. And a lot of this data is from 6 months worth of pandemic too, because I did a lot of telemedicine during that time. So there was a ton of video calls and text messaging and things like that. And so I try to just work it in throughout the day. To be honest, I'm not good at that kind of thing. I'm not good at, oh yeah, I got to check the email. Oh yeah, I got to check this. So my assistant helps me with that a ton. And so we regroup twice a day or so. And she says, hey doc, this came in, she's an RN. This came in, this came in, this came in, this came in. These were the results. Do you want me to file these? And I now have an incredibly great filing system in Atlas that I love. So for people who use Atlas and haven't found their thing yet, if you're interested in mine, I have 5 categories. It's labs, pathology, images, consults, and records, I think. And so it'll be like image, CT, parentheses, normal, /date, /patient name. And so when I'm looking for something very quickly, I can just quickly scroll through, oh, I need that image, there it is. Or I need that consult note, there it is.
This is what I love about the idea that if you've seen one DPC, you've seen one DPC, because I'm sure you just helped a bunch of people with regards to learning a new way to organize their EMR. So thank you. That's amazing. Now, one of the things that I'm laughing at in your data, because I had 63 messages in one day in my fee-for-service inbox, but your lab results, you had 696 over the 21-day period, and on average 2.2 a day. And I'm just like, that's amazing. So could you talk about how you seem to get that number because that's almost a dream.
Okay. That's another thing is I don't have to order a ton of labs for people who don't need them. And I have time to explain why they don't need a lab. I also don't have that many patients, in a fee-for-service world where a panel is 2,000 patients or more, 4,000 patients even sometimes. I don't know. I'm thinking if you get 1% of labs a day, that's a lot. You can't keep up with that. It's impossible.
I've never seen a day that I had only 2.2 labs in a day. So amazing. And appointments. That's a big thing for those people who are interested in DPC, but are like, how many do you actually see in a day? You had 2,767 and 8.8 per day on average. And so can you explain how you do it so that you're not seeing the 20 patients a day like you were at Fort Hood?
Yep. My panel at Fort Hood was a lot bigger. My panel was like, I can't remember now, 1,200 or 1,800 or something. And I was seeing other people's patients for urgent needs. So I think a lot of it is also, I don't need someone to come in and pay a copay so that I can bill something like a 99212 just to go over normal labs. I don't care about that. I'll text them and tell them their labs are normal, or things that don't need an appointment. A patient called me that I hadn't seen in a while, said I need a refill of my blood pressure meds. And I said, well, I haven't seen you in a while. How's your blood pressure doing? And he said, actually, I haven't been taking it that often. Let me take it right now. Oh, it's 117/74. Perfect. Glad. It's going well. No symptoms. Here's your refill. Call me if and when you need me.
And you're totally accessible if and when he needs you.
Mm-hmm. Yeah. So many people just walk in off the street. One guy came in, knew that I would be furious with him because his blood pressure was 180/100. And I said, what in the world happened? And he said, well, I haven't taken my meds for a week. Okay. Yeah, that'll do it. Why haven't you been in? Well, I knew you were going to be mad at me. So I said, well, let's get our meds restarted and see how your blood pressure does.
Oh my goodness. I think about how, like, being in a small town, I have totally had those reactions where people will talk to you like you're a family member, like you treat them like a family member. But it's just something that somebody who is in a panel of 2,000, a panel of more than 2,000, that do they know that doctor? Do they expect that type of relationship with them? And
you can't know that many people. It's not safe.
Yeah. And I look back on my own panel, and for some patients, I'm like, I haven't seen this person in 4 years. So how am I supposed to know everything that happened? And so I am glad that your patients know who you are and they are keeping in mind that you actually care about them, because even the idea of him thinking that you would be mad means that he knows that you care.
Yeah. I had another set of patients, a husband and a wife, who I didn't think they liked me at all. I thought the wife liked me okay, but I thought the husband hated me. And I felt so bad. He had this new sudden onset dyspnea on exertion and some very stable angina type symptoms, not sudden onset, but progressive onset. And so I explained to him why it was important to get a stress test, especially with his family history, especially with obesity, blah, 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 blah. And he was furious. And I thought for sure he was going to quit. And it turns out that I'm his favorite doctor that he's ever had. And they invited me and my husband over for dinner, and we're going to go. I think you do need to have boundaries, and you can't do that with everybody, but this is a small town and I'm a business owner and they're fellow business owners. And I just blew my mind when, very similar to that, took his A1C, trusted me enough to get him started on insulin. He wouldn't even take metformin before. And I got him on insulin eventually. He has lost so much weight. He has come almost completely off of his insulin, and his A1C is in the 6s.
Amazing.
It is incredible. There's no way I would have had time like that, or that he would have gotten comfortable enough for someone to be able to allow them to start an injectable. It doesn't happen when you're seeing 20 to 40 patients a day. Yeah. In most cases, I think.
You shared that Dr. Samuel was very much traditional and he had paper as well as practice fusion, but texting wasn't really a thing that patients were used to. So how did it go when they needed to use tech like video calls in your practice during the pandemic?
There was a huge divide. They either loved it and were super grateful, or they hated it and they wanted to be seen in person, and that's how they'd always done it, and that is what they will do. Furious if I did a car side visit, or furious if they had to wear a mask. No one here masks. No one in North Idaho masks. And they do large gatherings, a very loud minority, or the majority don't care.
And in terms of your video visits, were you using video visits through Atlas, or were you using a different platform?
I used Doxy.me for the most part. It seemed a little more reliable. Maybe not reliable is not the right word. I don't know. It just, that was what I tended to use, and it worked fine. Well, that's another thing. I guess in the Army, I was in a CBRNE unit, which is chemical, biological, radiological, nuclear, and explosive warfare unit. So we literally trained for stateside disasters, such as pandemics. And we had to be ready at a moment's notice to be deployed to a stateside disaster. And so I loved being able to make my own decisions about this and do what I wanted to do in my clinic, how I wanted to do it, without having someone else tell me, I'm sorry, you have to reuse your N95 for a week. Or, nope, I'm sorry, you actually have to see all those sick visits in person.
And when you were in that space of, wow, this is exactly what I trained for, and now I'm having to use it, and I have the skills to design my own practice around this pandemic, what were some of the strategies that you put in place specifically so that you could serve your patients the best in addition to what you've already mentioned?
My husband actually recognized it incredibly early. So December, he was like, "Oh, Jenna, this is going to get bad." So we just ordered a bunch of supplies and we inventoried them, masks. We estimated it at the rate it was going in about March. It hadn't quite hit us yet. So I estimated how many sick patients we would be seeing and what kind of equipment we would need for that. And then I just extrapolated that, bought enough for a quarter. And then every month we would check it and see how much we had if we were doing it right. And then we had sick visits had to be done by video first. They had to be triaged by our manager / MA. Then they had to be done by video first. Then if they needed to be seen, it was car side in full PPE, and only well visits could come in, but they had to mask. And that was only if they demanded a visit or really needed it. I recommended that they push out, especially since by that point I had met everyone and knew everyone, almost everyone.
And do you have patients who don't have internet?
Yeah, I have a couple.
And how did you manage their
They
care?
still have cell phones. So we FaceTimed or whatever.
Reflecting on your time at Fort Hood and just the fact that you were serving in the Army, I'm sure that you were dealing with a lot of mental health issues. And so I wanted to go back to the fact that you have, and you said included in your membership is our counseling services. So can you touch on that portion of your practice, please?
Absolutely. So when I decided that I wanted to quit medicine, it was when I went through a very severe depression. The tipping point was when I had an emergency oophorectomy because I had a very large cyst that they thought was cancer. Thank God that it ended up not being cancer. But so I recognize it not just in my patients in the military, but also in myself. I can't get disability insurance now, despite running an incredibly successful practice and getting through medical school and being a doctor. Like, who wouldn't want to insure that type of person? But not only is it close for me just personally, but seeing it in my patients too. So I think that DPC can be way, way more than just a physician-patient relationship. So I pay a counselor a part-time salary and patients can make appointments with her. And it's included in membership. She just uses one of the rooms. I also would like to do this with massage therapy and a lot of other services as well. So I want to give them the space. I'm closing on my building that I'm in. So my building has 3 units in it and I'm in 1 unit and there's an insurance in the other 2 units. And when that insurance agent retires, I'm going to take over the whole unit. And I want to give this space away. I want to have people who will come in and see my patients either for free or at an extreme discounted rate. And then they can build their own practice within that as well. They just have to see my patients and give them really good deals because I'm going to give them free rent. So I think there can be a lot more to it. Oh, I've got to tell you one more thing too. I'm so sorry. I'm going to keep you here all night.
Go for it.
My long-term goal, so my 15 to 20 year plan is I want to have a network of direct insurance, lab, path, radiology, and I'm missing one. There are 5. Pharmacy. And I want to have a direct care network. The insurance would be more like a co-op or a health share type thing. But I want to be the CEO of this company and pay myself no more than the lowest paid person of my company. And I want to set an example. And I want these to be for direct care doctors. I want direct care physicians utilizing this only for their patients. It won't be for anybody else. And it will be them getting it at cost or just like maybe 10% above cost. And then I'm going to take out a third middleman. I'm not going to have to buy from a wholesaler because I'm just going to give it to the patients. Or you wouldn't have to buy it from LabCorp because you would just send me the blood and I would run it for you at my cost. So if I'm paying LabCorp $5 for a CBC, it probably costs them $1 to run. So then it's only costing you $1 by that point. I don't want to make a profit on this. I want this to be, I've got to make my money doing something else. I don't know what, but it's going to be nonprofit. And I'm going to try to set an example for how healthcare should be in our country.
Just hearing your story from where you were at Fort Hood to taking over a practice and then dreaming and planning already for the 15 to 20 year plan. It's just incredible. Could you even imagine that this is the space that you would be in when you were in those days of seeing 20 patients and supervising mid-levels and taking care of having to travel as well as be a physician at the base? It's just incredible.
And to travel, you would have to fill out like 8 pieces of paper and take them to all kinds of different departments and have different signatures. And they were only open on Tuesdays at noon, or it was awful. It's impossible. But yeah, I have gone a complete different direction in my life, and I could never have imagined this, and I couldn't be happier. I think every doctor deserves this.
Now, I want to ask, because with every doctor, and I am totally with you on that, and every doctor deserves this, because this is allowing us to fulfill our calling to medicine and to be able to do the things that we want to do for patients, the way we want to do them for patients. But with you adding Dr. Odom in the fall, I want to ask about, now, how did you find Dr. Odom on Facebook? Did you find Dr. Odom a different way?
On Facebook. So I have a friend who I went to residency with, Dr. Pierre is her name, Fiore, and she called me up one day and said, "Hey, Jenna, I have a friend here, a colleague who has been interested in DPC for a while. He's been thinking about it for a few years, and he's getting out next year. He'd like to talk to you." I said, "Oh, I'd love to talk to him." So he called me up, and I said, I felt like there was a really good connection and that we could work well. He's in the Air Force, so he's also military. He gets the lifestyle and everything. And so I said, let's just say we partner. And he was like, "I don't even know you yet." But it turns out he came here for an entire month, and he saw the area, met a ton of my patients. And I asked them up front, I said, "I'm having him here to make this offer. I want him to work with me and us cover for each other when I'm ever on vacation, or if I ever have to call out. So there's a doctor in the office." And most of them were like, "Yeah, he's great. He's amazing. We love him." And a select few were like, "He told me I needed to lose weight and stop smoking." And I was like, "You do." But yeah, it was, I forgot what the question was. How did I meet him? Through a mutual friend, and now they're coming. And he's with his wife. They have twin 4-year-olds. They're, I think, about to be 5 or just recently turned 5. And yeah.
When you were like, this could really be my future partner, what were some of the questions? Because you had excellent questions when you decided to buy the practice. What were some of those questions that you had for Dr.
We got to work together for an entire month. So I saw him every day. I learned about his personality. I learned what his goals were, what his aspirations were. I feel like he is a more detailed oriented person, and I'm a little bit more of a 15, 20-year planner. But I asked him things like, "What would you do if this happened?" And he also asked a lot of those things like, "Jenny, we have to plan for everything. You never want something to fail, but what if it did? What if we work together for a year and we don't like each other?" And so we just talked about those things, like how we would split patients. What would happen? Would it be amicable? I'm pretty outspoken, but I also love people. So if it doesn't work for someone, I'm not going to force them to stay. I want them to be happy. I want everybody to be successful. Yeah.
When he comes on, will he earn his keep, so to speak, based on the patients that he is accepting off the wait list, or is he going to be employed? How is it going to work out?
I'd be happy to send anyone the contract who wants to look at it, but I'm doing a guaranteed $8,000 a month salary for 20 hours a week, average of 20 hours a week. And after that, I think it said we split like every 50 patients, 50 will go to the practice and 50 will go to his salary until he reaches, I think we said 6,500 or 600 patients. And my goal for us, and we'll talk about this and figure it out for sure, but I would love to be making $300,000 a year, working 4 days a week, and have a full practice.
While we're talking about numbers, what is your overhead?
Overhead right now for me is high because I'm doing a lot of marketing and just prepping for getting him on board. I think it's about 40%. Let me see. Yeah, it's about like 38%.
Gotcha. And when you look back at the idea of buying a practice again, do you have others reaching out to you who are asking about how you did it, or asking for advice as to how to buy another DPC if they're looking into that?
I've had a couple people ask about that, and I just tell them my experience, how much I paid, how much they were asking, how much, what kind of questions I asked, and if it was a good thing or not. And most DPC practices, I feel, aren't for sale. Either it's partnership or something like that. I've only seen a couple for sale, I think.
In terms of you being in practice since 2019 and being in the position that you are, having bought a business, what are some of the questions that you get most frequently from those who reach out to you?
Can I do it? Is it possible? I don't think it's possible. And I tell them it is incredibly easy to make it possible. We're brainwashed. Doctors are brainwashed. I say to someone, if they call me up and I just ask them, I say, okay, how much money do you want to make? I'm not sure. Maybe, I don't know, 180,000 a year. And I'm like, you're undervaluing yourself, but let's see. If you do 180,000 a year, that means, and I also ask, how many patients do you want to see a day? Okay, how many days a week do you want to work? Okay, well, then your patients are going to have to pay this much per month. And it usually ends up being like $75 to $90 a month on average. And they're like, why would people pay for that? And I'm like, value. They love relationship. They want something of value. People, and that's the kind of person you want as a patient. You want the people who value you as a person. You are not a cog in a wheel. You are not, we're brainwashed. You don't need to be working for a company or a corporation. They're making like $1.3 million off of you a year and they're paying you $150,000 or $200,000 a year, and they're working you like a dog. Why not make more and work less and make more? It's doable.
For those who can relate to that experience or that feeling that you described when you were in that corporate army medicine to now, it's so inspirational. So those words are words to take to heart and just insert into your potential future dream, your future 15 to 20 year plan, if you are on the cusp of thinking about DPC.
I've literally never been happier in my entire adult life. I never thought I could love this much, ever. Not even in med school when I was having dreams of what I thought medicine was going to be like. I went to the Philippines on 2 mission trips, and I was like, this is amazing. People are grateful. They're thankful. They listen to what you have to say. They want to hear what you have to say. And I thought it would be like that. And it was not. It was a lot of paperwork, a lot of administration. And now I just couldn't be happier.
Can you describe your most difficult day in DPC thus far?
I like to say that, and this is not really a description of my day per se, but my worst, hardest day in DPC is about 40% of what my average was every day in the Army.
Incredible.
Yeah.
And so sad.
I really can't think of a worse day. I mean, I remember a couple of times just tearing up at the end of the day, being overwhelmed, thinking, oh, I'm worried about this person and I've got so many orders to put in, and just normal stress, I think, but nothing like what your normal stress is in the day-to-day corporate job, I think.
Yeah. That it highlights that reality that a lot of us face where even if fee for service, when we are with patients, we love it. It's when we step out of the room and when we have to do all of the other things and when we're restricted on doing certain things, that's where I think a lot of that burnout comes from. And so the idea that you're just always in that patient relationship place, it's just, if people think about it in that context, like how, with you sharing how you are living in that space, it just really paints a different picture for people. And the big picture with this podcast is to share how everybody is doing it their own way.
And you can take best practices and you will find someone who you can connect with and who did it like you want to do it. I love it.
So now going on a roller coaster ride, what is your best day in DPC?
The best day, one of the best days, is a patient who called me and said, I don't have any health problems. I don't have anything wrong with me. I just need to get this referral for my mild sleep apnea. I need this dental referral so my insurance will pay for it. And my doctor won't get me in. I've been trying for months. And I said, okay, no problem. You sound legit. So I did a quick video, documented everything, talked to her about her problems, her medical history, sent the referral. Then her mammogram came back to me the next day and said malignancy. So I had not yet seen this woman in person. And I called her and I had to tell her, I'm really sorry to have to tell you this, having not met you, but your mammogram actually came back as concerning for cancer. And I want you to meet me at the office. And so we had a discussion about it. I got her in for a biopsy. She had the biopsy and the results and 2 specialty consults scheduled before her other primary care doctor called to tell her about the mammo results.
As it should be, right? As it should be.
Yeah, it's crazy.
Wow.
There are too many good days to even remember them all. There are so many that are going through my head, and I'm like, I want to tell this story, and I want to tell that story, and I want to tell about this patient, I want to tell about this person. I love my patients so much. And one of them, I was sick this past week. They brought me, or they sent flowers, a rose bush to my office. And it's beautiful. I'm so thankful. So many texts and well wishes. It's incredible.
And I hope that you take pictures in the next 15 to 20 years of that rose bush and just see how it flourishes just like you will. Jennifer, those who wish to reach out to you after this podcast, what is the best way for them to contact you?
You can text me on my cell phone, and it's 740-339-9087, or message me on Facebook.
Thank you so much, Dr. Silakoski, for joining us today.
Thank you for having me.
Next week, look forward to hearing from Dr. Jalon Burton of Healthy Home Pediatrics in Washington, D.C. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends, too. For more information on this episode and much more, including DPC swag, please visit mydpcstory.com. Also, for the latest in DPC news, check out dpcnews.com. Until next week, this is Marielle Concepcion.